All right, so we'll go ahead and get started. We're going to talk a little bit about pulmonary function testing. And we're going to talk basically from a patient perspective. But I'm hoping throughout this talk that everyone, even though whether you're a patient or a caregiver, you'll be able to take some information back from this. Okay, so some of the indications for pulmonary function testing. This one here. Shortness of breath. So if you think back to the first time you had a PFT done, chances are you came in and you told the doctor, look, I'm having some shortness of breath. Some people think that shortness of breath is just because I haven't exercised in a little bit, but if it persists, then usually you'll come in and tell the doctor, look, something's going on here, and they look into it and probably will be ordering a pulmonary function test. Chest tightness, that's another indication for pulmonary function testing. Wheezes, cough is a big one. Some people have a persistent cough that they can't get rid of, so they actually come in and see the doctor for that. Progression of disease. So now we're talking about all the different reasons why you would have your first pulmonary function test. How many people has had a pulmonary function test? Yeah, it's a lot. As a caregiver, we also do pulmonary function tests ourselves because we have to make sure the machine is functioning. For progression of disease, these are patients that are like scleroderma, lupus, sarcoidosis. They also get pulmonary function tests to check to see how their disease is progressing. Significant history of smoking. So for those that have smoked a very long time, sometimes we get pulmonary function tests, but it's usually in conjunction with some of the other things. So if you've smoked for a very long time, but now you also have shortness of breath, those are indications for getting your first pulmonary function test. Evaluation of surgical risk. Some patients have surgery, and before they actually do surgery, chest, usually something that goes on with the chest, they will order a pulmonary function test to just evaluate and make sure that you'll be okay doing your surgery. All right, what is a pulmonary function test? It's a set of breathing maneuvers designed to measure lung volumes, capacities, flows, and diffusion of gases. And we'll talk a little bit more about that as we go along. It's used to diagnose obstructive and restrictive diseases. And there's vascular diseases as well. It's used to monitor and trend lung function. And it's used to monitor progression of disease. So even though you get your first pulmonary function test and you've been diagnosed, those tests are repeated on an interval basis so that we can monitor the progression of your disease. All right. There's a lot of different types of pulmonary function tests. So what we're going to talk about are the ones that's most common and probably the ones that you would see as a patient when coming in for your doctor visits. So the first one we're going to talk about is spirometry. Spirometry is probably the most common, and sometimes it's done in conjunction with your complete pulmonary function test, and sometimes it's done as a solo. So we'll talk about that. We'll talk about diffusion capacity, and we'll also talk about lung volumes. All right, predicted normals. That's probably the most asked question I get as a person that do pulmonary function tests. what's normal? And that's a big loaded question. What we do to predict normals is that we look at several factors. Race, height, your age, gender, and with these different things into play, research is also involved in creating normals for PFTs. So there's research studies that's designed, and they look at all of these factors. And what they do is that they actually analyze patients that are considered without lung disease at different ages, different races, different genders, and they all put together what's normal based upon the average for normal patients. So spirometry is the first test that we're going to talk about. Like I said, it's the one that's most widely used. And we do spirometry in several different forms. We do them based on a machine like this that you see in the picture. It can also be done in a body box. But usually the body box, when doing spirometry, the door is open. So it's not a closed test. It's just done inside of a body box where the machine mouthpiece is located. And then we also have handheld spirometry. So they're done with just a little small handheld device, and we were able to get testing from that as well. The major components of spirometry is the FVC, or forced vital capacity. And what that is the maximum amount of air that you can forcefully exhale in one single breath. So usually we have a patient to take regular breathing, do regular breaths, and then we're going to go all the way up until we get totally full. And then we're going to blow it out hard and fast. And that gives us our FVC. Along in the line of the same test, same breath, we're also going to get the FEV1. And that is forced expiratory volume in the first second. So when you take that deep breath in, you get all the way up into maximum, you blow it out hard and fast. Most of your air is going to come out in that first second, because that's the air that's coming from your larger airways. So when you exhale, that first second is expected to be about over 70% of your breath in that first second. And we get a ratio, which is FEV1, FVC, which is a ratio of how much of that total breath is in that first second. Again, we're looking at greater than 70%. All right, so when we do a breathing test, we start out with just regular breathing, and then your person that's doing your test will tell you to take a deep breath in. So you're going to take a breath in, and then they're going to say blow it out hard and fast. So you're going to blow it out and come down. The reason why it comes out this way, because again, your larger airways are going to be the first one to expel air. And as you get closer down to the end of your breath, the flow actually gets lower, because your little airways don't carry as much air. And then at the end, we're going to tell you, take another deep breath in. So we're going to close the loop. So this is what it looks like on the screen when we do a pulmonary function test, if you have normal lungs. The obstructive lung actually has a curve in it, more like a boot. And that's because they can take a big deep breath and they can blast it out, but the small airways have issues getting the air out. So it takes a long time for patients with obstructive disease to get the air out of their breath. And then here on the third one is a diagram of a person with restrictive disease. They don't have the little boot shape like this one does. They're actually pretty similar to the one that's normal. The difference is that the volume is smaller. So as opposed to having 6 or 7 liters of volume in their lungs, they have a smaller amount of volume. So that is a restricted disease. And then one that's pretty uncommon is a larger airway obstruction. All right, so after we do the breath, after we tell you to take a deep breath in and to blast it out hard and fast, we get numbers from that. The first set of numbers on the screen, predicted. We talked about predicted normals based on race, age, height, sex. And so it tells us based on your age, height, weight, and sex where you should fall. So that's our predicted. And then we're going to get actual numbers. So from your test that you just performed, what numbers did it generate? And then from that, we get a % of predicted. Now, what's normal? We consider normal anywhere from 80 to 120%. That's the normal range. So according to these numbers, this person is considered normal from the breathing test, although there's other tests that can further give you more information. So we have 81% on the FVC, 89% on the FEV1, how hard and fast they blew it out in that first second. And actually here is where we're looking for a number, and that's the percentage, that's 79%. Again, we want everyone to be greater than 72%. So of this test, this is actually considered a normal test so far. All right, so normal. What's considered normal? Everything is normal, right? Normal is normal. COPD is an obstructive disease. So on their COPD, and that's considered emphysema, asthma, chronic bronchitis. They have airway obstruction problems. So their FVC may be normal or may be low. The FEV1 will be low, and the ratio will be low because they have problems exhaling the air out during the test. IPF, and actually it should be ILD, because IPF is one form of ILD. But ILD is a restrictive disorder, and you will have either normal or low FVC, normal or low FEV1, and your ratio is absolutely normal. So when you look on your report, we actually, in the support group, we actually took everyone and gave them their own report. And we said, I don't want you to look at numbers on the board. We want you to look at your numbers. And we took that test and we looked at, every patient looked at their numbers to try to get an understanding, one, why am I doing this test? But two, what information is gathered from the test? So it's all about educating and making sure everyone knows exactly what's going on. All right, sometimes we do tests and we give a medication called a bronchodilator. Bronchodilators are not particularly helpful. Sometimes they are, depending on your condition, but on a grand scheme, it's not particularly helpful for patients with pulmonary fibrosis. So it's used to determine if the medication can be helpful. So usually probably around one of the first couple of tests that you had, you get one with a bronchodilator, and it can be in an inhaler or it can be in an aerosol. So you get that medication. First, you're going to do the test first, the test that we were talking about. Then you're going to get the inhaler, and then guess what? We're going to come back and give you that same test again, because what we're trying to determine is that medication beneficial to you as a patient. So if it's beneficial, then chances are you're going to get an order or a prescription for that medication because it has shown that that medication is helpful for you. Also, if your ratio, which was the last one on the previous screen, if it's less than 70%, chances are you would get this bronchodilator. If your test is absolutely normal, you may not. All right. A little crazy screen, huh? Sometimes patients tell me this. How long are you going to tell me to hold my breath? How long are you going to tell me to keep going? So it sometimes feels this way when you're doing the PFT as a patient. All right, what affects results? One is have a good coach. And sometimes it's better to have the same coach because people have different techniques on how they coach you through the test. But if you're having a good coach, they can actually gear you toward doing the best test that you can. Acute illness. So if they are sick, it's probably not a good time to do your pulmonary function test. Trying to save your air, a lack of understanding what to do, and giving your best effort. And again, medications. If you had that medication before, it will affect your test to show that it's unofficially high. So why you have to do it so many times? There's the ATS guideline. And we want you to make sure that your test is valid. So there's a minimum of 3 and a maximum of 8. And it must be reproducible and it must be repeatable. So sometimes we have to throw tests out because it doesn't look like the others. So we want to make sure that that test is intentional and it captures everything in your test. We want to make sure that there's no cough in the first second because, again, we want to make sure that we can get that FEV1 in order to validate your test. No hesitation. It must be at least 6 seconds, and it must have a plateau or emptying of air. All right, DLCO. It's the second test we're going to talk about. And it is a test to measure the ability of your lungs to transport oxygen from your airway sacs into the bloodstream. All right, how it works. When you have pulmonary fibrosis, your lungs have scarring. And so the air sacs lining is thick or can thicken. And so when this test actually allows us to see how, when given a known concentration of gas, how it actually crosses that membrane and go into your bloodstream. So we have a known concentration of gas. You're going to exhale, and then you're going to inhale that breath and hold it for 10 seconds and blow it out. And what we're doing is we're measuring how much you actually inhaled, or the concentration that you inhaled, and then what is blown out. What does not come out is either inside your bloodstream or is actually trapped in your air sacs. And this is just a picture of how your oxygen crosses over into your bloodstream, and then how you expel CO2. What affects the DLCO is changes in your air sac or progression of disease, your hemoglobin count. You must have a maximum effort, and there's no leaking around your mouthpiece that can give us false numbers. All right, lung volume. The third and final test that we're going to talk about. There are volumes of air, and then there are capacities. The volume of air is just segments of different air segments. And those are listed there. Tidal volume, inspiratory reserve, expiratory reserve, and residual volume. And then capacities actually combine volumes. So those are the different capacities listed there. And we'll look at them on the bigger screen. So if you look on the black row, those are your volumes. So you're breathing your tidal volume. That's just regular breathing. Everybody's breathing tidal volume right now, except me, probably. And when you take a deep breath in, you go into your reserve. So you're actually pulling in all the air until you get into maximum. And then you're going to blow it all the way out. You're going to go past your regular breath, and you're going to go into your reserve on the expiratory side, and then go back to regular breathing. And that's what we call a vital capacity maneuver. On this chart, you can see the capacities where inspiratory capacity combines these two. Expiratory functional residual capacity combines these two. Vital capacity takes everything here, from the maximum to the most you can exhale. And then there's this little guy at the bottom that's called residual volume. That's the air you cannot exhale. It's actually the air that's in your lungs to prevent your lungs from deflating. So it's there, and it won't go anywhere. And then to take an account of every single thing, you have your total lung capacity. The difference between restrictive and obstructive. Restrictive is the pulmonary fibrosis, of course, pulmonary edema, obesity, scleroderma, and sarcoidosis, just to name a few. And then the obstructive diseases are the big lung diseases. It's COPD, chronic bronchitis, and then asthma. Again, pulmonary fibrosis is a restrictive disease. All lungs and capacities are reduced. Expiratory flow can be normal. Lung diffusion is affected because that's where the inflammation or the thickening of the airway is formed. And the characteristics: shortness of breath, cough, can't take a deep breath in. So in summary, pulmonary function test is very important to the pulmonary patient in terms of diagnosis and treatment. It is restrictive. COPD is obstructive. And some patients may have both. Diffusion of the lung can be involved, resulting in the use of home oxygen. So, as a patient, what is your responsibility? One, we want you to assist the physician to manage your disease. Make sure your doctor knows all about your health. Write it down if you have to. Bring it in with you. Take all prescribed medication, including oxygen. Some people forget oxygen is a medication. So we want to make sure that we can stabilize your disease and get you on the right path. Give your best effort to validate the test. This test is patient dependent. Unlike a blood test where you go and get the results, has nothing to do with your ability to perform. It's just there. But this is a patient-driven test, and it depends on the best effort that you can give. Trend the values, not the actual numbers, because sometimes the numbers do change. Sometimes some days are better than other days. And what we're looking at is not just an individual test. We're looking at how are you trending. How are you getting better? Is it getting worse? But just don't worry about one number. And this is my favorite. PFTs alone don't determine your severity. Severity is based on how you live and how you feel. We want to make sure that you're living life to the fullest. And we're here to do whatever we can to make that happen for you. And that's all I have. Thank you.